and thank you for joining us today. My name is Michelle Shalgin, and I am the Chief Strategy Officer at the Patient-Centered Primary Care Collaborative. The title of today's webinar is Building a Statewide PCMH Program, Design, Evaluation Methods, and Results, and we are very excited to feature the excellent work of Blue Cross Blue Shield Michigan and their statewide PCMH initiative. I do want to let you all know that the slides and the recording will be available on our website within the next 24 hours, and our website is www.pcpcc.org. You can click on webinars at the bottom, but that will be available for all of you within the next 24 hours. Before we begin, I did want to make one announcement. For those of you interested in population health management, we'll be hosting a webinar on November 12th that provides a deep dive on our recent publication on the topic. This was released last week during our conference. The report provides a primer for using population health management in the medical neighborhood and also includes a top 10 list of recommended health IT tools used in population health management. The webinar will include Jan Sidorov from Sidorov Health Solutions, and he's also the writer of the Disease Management Care blog. We'll also have Robert Fortini, Chief Clinical Officer at Bon Secours Virginia Medical Group, who will talk about the strategies they are using in the field and the results they've experienced. Bon Secours is also a featured case study in the publication. So that is November 12th, and the publication and the webinar registration information are available on our website at pcpcc.org. So before I introduce our speakers, I did want to let you all know that the reason we are so excited to be featuring Blue Cross Blue Shield Michigan's work is there was an article published in July of this year in the Health Services Research Journal that looked at the relationship between the degree of a practice's implementation of the PCMH model and measures of cost and quality of care. I think this report is rare because rather than showing a before and after, it showed levels of progress along the way to each practice's PCMH goals. Without stealing any thunder from our Michigan group, the findings demonstrated $155 million in savings and nearly $27 lower per member per month cost over the 3 years, which is exciting, and they'll talk more about that today. You'll first hear from our presenters, and then we'll have an opportunity for Q&A after the presentation. You can participate in the Q&A by typing your question into the question box on the bottom of your screen. We do have over 400 registrants for today's call, so we will try our best to accommodate everyone's questions. And now I will introduce our speakers. Today we have Margaret Mason. She's the lead developer for Blue Cross's Physician Group Incentive Program, Patient-Centered Medical Home, and Organized Systems of Care programs. We also have Michael Postian, who's worked with Blue Cross for the past 5 years in developing and evaluating clinical programs aimed at practice transformation and improving healthcare value, including the PCMH program. He is also the lead author of the July 2013 study. And finally, we have Amanda Markovitz, an epidemiologist in the Department of Clinical Epidemiology and Biostatistics at Blue Cross Michigan. So first, we have Margaret Mason, who will start us off with Blue Cross's presentation.
Thank you, and hello everybody. Glad to be here, and thanks for joining us. I'm going to click the slides here. Okay, here we go. First, I'm going to just give you a little quick snapshot of Blue Cross Blue Shield of Michigan as a plan. We serve over 4 million members in Michigan, and we also have over 1.1 million out-of-state members. We have about a 40% market share in Michigan. And we are nonprofit, and we have the largest network of providers in the state, more than 158 hospitals, which is 100% of all Michigan hospitals, and nearly 30,000 physicians, which is 95% of all Michigan physicians. And we process a lot of claims, and we pay a lot of benefits. And we also have 4 subsidiaries, including an HMO Blue Care network. So today I'm first going to give an overview of the PCMH program that we've developed, and then Mike is going to talk about the site visit process. Amanda will talk about our designation methods in detail, and then Mike is going to talk about the evaluation. We first started our journey to develop a patient-centered medical home program when we were visited by aliens, and I'm just kidding, but we actually we did start because we felt that we needed to address the primary care crisis and the shortage as well as the overburdening of primary care physicians. so we had meetings with a number of physician organizations around the state, and we decided to partner with them. And to us, it made sense to work with these physician organizations. And when we first started, there were not a lot of them in the state. There were 10 or 12, but in our program, we provided a catalyst for physician organizations to form, because we felt that working with physician organizations, we could, number one, do population level measurement and also reward performance at the population level. We also recognize that physician organizations would be better positioned to have the structure and technical expertise to enact practice transformation. And we also wanted to develop these programs collaboratively. And so we were able to work with the physician organizations to launch the PGIP program in 2004. When it was initially launched, it was based on the chronic care model. And then as the program expanded and more physician organizations formed and more physicians joined, in 2007, we began developing our PCMH program, which we launched in 2008. And at the same time that we launched our PCMH program, and I will go into that in a little bit more detail in a minute, we also launched what we call quality use initiatives. And those are opportunities for physician organizations to specifically focus on a particular area, such as, for example, preventable emergency department use or high and low-tech imaging, and work to improve their performance. And we then measure their performance at the physician organization level and reward them based on not only absolute performance, but also degree of improvement. Also, at around that time, we added two specialty types to PGIP, cardiologists and endocrinologists. So we worked and expanded our PCMH program for the next several years. And just to give you an overview of where we're heading, we are now building what we call organized systems of care. It's really quite akin to ACOs, but again, it's something that we have developed collaboratively with our provider community, and it is being built on the foundation of the PCMH program. So we have specialists now working to implement the PCMH capabilities, building out the PCMH neighborhood, and we also have hospitals engaged in working on implementing many of the same capabilities and shared care processes and information systems. And I have a reference to an article that was in Health Affairs not too long ago, if you would like more information about our PGIP program. Just some quick statistics. As of this summer, we have over 40 physician organizations across the state, 18,000 physicians, including 5,800 PCPs and 12,000 specialists, 5,800 practice units. And as I mentioned, we have initiatives. We now have 30 of them that both support PCMH activity implementation, organized system of care implementation of capabilities, as well as rewarding the performance and improvement of the physician organizations. And we are affecting the lives of nearly 2 million people across the state. There was a University of Michigan evaluation completed recently that found that PGIP practices have a 5% lower cost overall compared to non-PGIP practices. So our PCMH program consists of two components, and we took the approach that we needed to support incremental implementation of the PCMH model. So we designed 12 initiatives that support implementation of discrete capabilities, and we spent a lot of time working collaboratively with our providers to develop each of those initiatives and to define those capabilities. And we decided that for the initiatives, all PCPs and specialists should be able to participate. And what we do, we have a PGIP reward pool that we fund through money that we are no longer giving across-the-board increases to our physicians. We haven't since 2009. Instead, we are moving to a fee-for-value approach where we have focused increases. And so with that money, we have a reward pool. And out of that reward pool, we pay the physician organizations when their practices implement PCMH capabilities. And that is self-reported twice a year, and we make those payments. The designation program then becomes the opportunity for those practices that have made progress in implementing PCMH capabilities to be recognized and also to earn additional rewards. We give a 10% increase in the E&M office visit services to the PCMH designated practices. And then in addition, we do a measurement of the total cost performance across all settings of care at the physician organization level, And those designated practices that are in one of the so-called cost benchmark performers get an additional 10% increase in their office visit fees. These are the first 6 initiatives that we implemented in 2008. And there is, I'm not going to go into the detail, but as you can see, there's brief descriptions of them. There's patient-provider partnership, patient registry, which we regard as really foundational, more so even than electronic medical records, performance reporting, and then individual care management, extended access, which has been a really key domain I think you'll see when you hear about Mike's results, and test tracking. And those were launched in 2008. And then in 2009, we developed and implemented 6 more initiatives. These domains were preventive services, linkage to community services, self-management support, patient web portal, coordination of care, and specialist referral process. We learned early on that we needed a lot of iterative dialogue with our providers around the state for them to understand the domains and the capabilities, and for us to get a better understanding of what was capable, what they were capable of implementing, and variations that we needed to account for because of rural areas or underserved urban areas. So we worked, again, collaboratively with our provider community to develop what we call PCMH interpretive guidelines. And at this point, they are now over 50 pages, and it goes through each of the 12 domains and outlines the capability and then lists definitions and examples to help providers understand what it is we would like to have them be implementing. And we formed a team, I should mention, we formed a team of clinical leaders from around the state, and met actually in the first year we did this, we had, I think, 3 all-day meetings in which we went through each page of the interpretive guidelines and incorporated everybody's feedback. And we do this annually now. Every year we update those guidelines based on the input we've gotten from our site visit process that Mike will be talking about, and the things we've learned during the year. Our designation process takes place annually, and a very important component is that the physician organizations nominate the practice units to be considered for designation. We felt it was really important to recognize that the physician organizations were in the best position to know which practices were really engaged in the PCMH model and had made the most progress. So we calculate scores, and Amanda's going to go into a lot of detail about this, but just to give you an overview, we calculate scores. 50% of the score is based on the PCMH capabilities that are in place in the practice. And this is one of the only times in our program that we actually do measurement and scoring at the practice unit level as opposed to the physician organization level. And the other 50% of the score is on quality, use, and efficiency measures. So we look at both. And the practice units are expected to continue to improve each year. And in fact, up until this year, every practice unit was rescored and had to re-earn designation annually. Just this year, though, because we felt that there had been enough stability in the designated population that we could implement an honor roll concept. And so now practices that remain designated 2 years in a row then can continue having their designation status unless they have very poor performance. So they're not included in the ranking process every year. And let's see, okay, there we go. Hold on, sorry, I think I just, oh, there we go, sorry. Okay, so we often get asked, why don't we just use the NCQA program? And there are several reasons. One is that we were actually developing our program at the same time as the NCQA program, and we were doing it collaboratively with our PGIP partners. So we felt that given the timing and also the importance of having a program that came out of our community rather than being imposed on the providers, we decided that we would use our own program. We also early on put more emphasis on care processes and less on IT infrastructure. And we also, as I said, felt it was really important to support incremental progress. So we wanted to create stepping stones, kind of a roadmap that practices could follow. Another thing, as I mentioned before, is that we also factor in the quality, use, and efficiency performance in our designation program. And finally, our site visit process, which Mike is going to talk about, plays a really important role in both educating our providers and enabling us to obtain feedback and spread the word about our programs. So in 2013, we have 13,000 PCPs and specialists implementing PCMH capabilities across the state, and 3,600 primary care physicians in 1,200 practices who are designated, and that affects about 1.8 million of our members. We pay out about $35 million in annual E&M uplifts, as I mentioned before, the 10% and the 20% uplifts, we call them there. That's the fee increase. We often get asked how our program fits within the entire state of Michigan. So if you look, you can see that there are about 10,000 PCPs in our network, in the Blue Cross Blue Shield network, and 69% of them have joined our PGIP program. And of those, more than half have ended up being designated. And 38% of the ones who are designated do earn that 20% uplift. We have designated practices statewide. This map shows actually the designation each year. So for example, the little red tents show the practices that have been designated since 2009, and then for each subsequent year. And we do have designated practices up in the Upper Peninsula as well. So we have a good statewide coverage. Here you can see how the number of practices nominated has increased each year. In the first year, we only had 667 practices nominated, as compared to this year, we had 1,300 nominated. And also you can see that in 2009, there were 300 practices designated, and now over 1,200. Likewise, the capability implementation has increased. In the first year of the designation program, we actually only looked at those first 6 domains that had been launched in 2008, those first 6 initiatives. So in the first year, the designated practices actually had, on average, about 65% of the capabilities implemented out of those first 6 domains, or 44 capabilities. And now we have, on average, our designated practices have 85 capabilities implemented, which, because we keep adding new capabilities each year, we've always added 2 or 3, is about 64% of the total capabilities. This lets you see the difference between the designated and non-designated practices in each domain. And at a population level, it is a distinctive difference in terms of the number of PCMH capabilities that have been implemented. And test tracking, preventive services, extended access, linkage to community services, patient-provider partnership have been the domains that where practices have made the most progress. And now I'm going to turn it over to Mike for the site visit process.
Thanks, Margaret. So I'm going to go further into the site visit process and kind of how we go about validating capabilities and how we use the site visits as well. So going through what happens in a site visit, how the site visits are selected, as well as how the site visit results are used. So this is just kind of an overview of kind of the process Margaret was going over about the interpretive guidelines. So you can see kind of here at the top where the interpretive guidelines are developed, and then they're communicated to the physician organizations. And as you mentioned, the interpretive guidelines consist of basically a set of case definitions for a lot of different capabilities. And those were developed with significant input from our physician community. So those guidelines get communicated to the physician organizations, who then use that information, and based on their understanding of those guidelines, report practice capabilities to us. And this is based on their interactions with practices. And typically, you might see physician organizations, some physician organizations will meet 2 or 3 times with their practices over the course of a year, whereas others will meet multiple times over the course of a year. That information gets reported to us twice a year. In December, when we get that information, we actually do a selection of site visits, and we'll actually send our field staff out to these sites to provide educational assistance, as well as to validate or verify the capabilities that truly are in place at the practice. The information we get back from those site visits, both from the practices themselves, as well as the physician organizations, as well as kind of the mutual observations that our field staff are having across all these different practices. All that information goes back into improving the interpretive guidelines for the next reporting cycle. So what happens in a PO site visit? So there's 2 types of site visits. physician organization site visits as well as practice site visits. So a physician organization site visit typically centers around the implementation strategy for patient-centered medical home in their practices. And for a new physician organization, this might require meeting on a more frequent basis because they're trying to understand the PCMH initiatives along with trying to develop their strategy. For a physician organization that has been around for a while, they probably need to meet less frequently because they've gone through a lot of these processes already. In addition to the implementation strategies around PCMH, there's also a lot of discussion around the performance metrics that we supply to those organizations, and many of those metrics are used in the designation process. But one of the main goals is to identify opportunities. We might find opportunities where one physician organization who's trying to develop an implementation strategy around one of these initiatives. We might know a physician organization nearby that has successfully done that, and they may want to partner in terms of implementing PCMH with that group. The practice site visits typically center around what the practice itself is doing, and typically these consist of meetings with both physician organization representatives as well as practice representatives at the practice, along with the Blue Cross field staff. So typically for about 4 to 6 months of the year, the field staff will be going on the road and meeting with various practices to review capabilities. And in these meetings, there's an effort to educate practices around implementing PCMH, as well as efforts to validate the capabilities. And so the field staff will actually use an Access database and conduct the site visits and record capabilities that they observe are truly in place. And that feedback then goes to help with the interpretive guidelines. So as Margaret mentioned, the program has grown quite considerably since we started, and so we've run into some challenges over time. One of those challenges is trying to maintain balance at the site visit between the educational purpose and the verification purposes. And you'll see through some of these slides how we've managed to try and achieve that over time. Also, our field staff has grown considerably over time. It started off with one field team member who actually did 114 site visits in about a 3 to 4 month period the first year, which is quite a daunting task. Currently, it consists of 8 team members, and some quality checks that have been added into this process as well, because you might get different interpretations across field team members, along with different interpretations from practices or organizations. There's been added weekly team meetings to help facilitate discussions around capabilities that were observed in practices where there might be questions, and in trying to resolve disputes on some of the guidelines in the midst of the site visit processes themselves. And as well as most recently this year, practices could volunteer as calibration sites to help standardize field team members. The site visit process itself initially began as a recommendation from POs as to which sites were visited. Since then, it has become a random sampling process, and I'll go into that a little bit further in future slides. And one of the things we noticed at site visits over time as well is that the replication of paperwork seemed to grow faster than the actual use of capabilities. And so we actually changed the format of the site visit from an interview style where we were asking for documentation of capabilities to really a hands-on observation of practices demonstrating their use of capabilities. And that has improved quite significantly the anxieties around having a site visit, because the practice staff themselves are much more comfortable showing us what they do rather than telling us what they do. In addition, we incorporated site visit feedback surveys, so after the site visit, practice can tell us about their experience with the site visit and how we might improve them. So this table summarizes our site visit selection process year by year. As I mentioned, the first 2 years, these were practices that were recommended to us for site visits. Just because of the way the designation program was set up at the time, those site visit results were incorporated into the program, so it was actually an adverse experience for designation purposes of having a site visit. So we switched to a random sampling approach as a way to make it a fair process of selecting site visits. We also modified how we use site visit results in the process, and Amanda will mention that more in the designation methods. We also switched, as you can see over time here, those first couple of years, site visits were taking 2 to 3 hours and then 3 to 5 hours. our first time doing random sampling, it took 2 to 7 hours at these site visits, in part because the number of capabilities these practices had implemented had grown so substantially that to review, say, 100 capabilities of the practice, it could actually take a full day to do so. So we modified the sampling process the next year and actually did a multi-stage sample where we actually select practices, and then within practices we select up to 40 capabilities. And this helps standardize the duration of the site visits. Instead of spending 7 hours validating capabilities, now they can spend an hour, working to validate capabilities and spending the remaining 1 to 2 hours educating the practice. So trying to reestablish that balance between education and validation. In addition, knowing ahead of time that a site visit is going to take 2 to 3 hours, if you have 2 practices nearby, you can, in theory, visit 2 practices on the same day. So it actually helps with scheduling site visits as well. So one of the ways that we use the site visit results is looking at what we call our accuracy factor. So this is just the accuracy in reporting for each physician organization. Just our sampling strategy, we try to get at least a couple practices per physician organization. And the first time we did it, we oversampled practices on the upper quartile of the capability distribution with the goal that if you see a lot of these capabilities, it'll help us actually see enough that we can revise the interpretive guidelines to really substantially improve them that first time. Our sampling strategy changed, as I mentioned, in the second year to try and minimize the burden both on our field team as well as on the practices themselves. And we typically focus, as far as accuracy goes, on the over-reported capabilities rather than under-reported capabilities. And then one of the main reasons for that is that the time it takes to review all capabilities is just too daunting. But then the PCMH incentive design, you're basically rewarding capability implementation in 2 ways. So in general, the design of the incentive itself would encourage over-reporting rather than under-reporting. So just how the accuracy has improved in the 2 times that we've done the random sampling. So the first time in 2011, 233 site visits. Overall, 91% of the capabilities that were reported to us were verified as being in place at the practice. But you can see by physician organization that there's quite a bit of variability in reporting. And in 2012, we saw the accuracy improve up to 95%, and some of that variability decreased. And this is just a look at back in 2011, looking by individual domain. Typically, accuracy is not uniform across the different PCMH domains. There's definitely certain areas where people struggle more with reporting capabilities, in part, so like self-management, support, and patient web portal, there's not as much implementation around there, so there's less knowledge to work with around what PCMH-ness looks like for those particular domains. We can also look at this at the individual physician organization level, and this particular physician organization looks pretty similar to what we saw with the overall distribution, but a little bit lower, and care coordination seems to be a little bit more of an issue for this particular PO than other POs. So this also helps us identify areas where we can develop focused education for POs that may need it. So just some of the impacts of the site visits and our routine process evaluation. It's really been a goal to have efficient and effective use of our time during the site visits, both to minimize the burden on the practices as well as ourselves, and really strike a balance in terms of the educational efforts that we need to provide to help support our practices, as well as the validation aspects to verify that what we're paying on is truly in place. It helps address a lot of physician organization concerns about differential reporting accuracy, though there's a couple of POs that still struggle. For the most part, most physician organizations have accuracy over 90% now. We've tried to minimize the adverse impact of site visits in the PCMH designation process, and Amanda will talk a little bit more about these 2 middle bullets in part of the designation methods. And then lastly, the site visits themselves have been really an important resource for evaluating and improving our interpretive guidelines, which are really a key component of our program. With that, I will hand it off to Amanda.
Thank you, Mike. So I'm going to talk in more detail about our designation methods. I'll go through who's eligible for the PCMH designation program and how we calculate PCMH capability and quality use and efficiency scores that Margaret mentioned. And then I'm going to talk about how we combine these into a single designation score and how we use that to determine who should get designated. And I have a reference to a paper at the bottom here that was published this year that talks a lot about these methods. So if you're looking for more information, that's a good place to start. So in general, who's eligible for our PCMH program are practices that are participating in the physician group incentive program that have a primary care physician. So we're looking at primary care practices, as well as those who have Blue Cross attributed members, so excluding ones that may no longer be practicing or don't see any Blue Cross members. So that's about 2,500 practices that become eligible for the program in 2013. And also we have requirements for calculating PCMH designation scores. Since we need a sufficient sample size to gain reliable metrics, we require that practices have at least 30 attributed members and that they have a large enough sample size to calculate 3 quality, use, and efficiency metrics. And each one of these metrics has their own sample size criteria, which I'll go into. And then this year we implemented a new component of this. We exempted safety net practices from these sample size requirements. Safety net practices frequently see uninsured or Medicare patients, so we didn't want to exclude them from the process just because they had very few Blue Cross members. So then after we use these requirements, practices also have to be nominated by their physician organization, as Margaret mentioned. So this smaller group of practices, about 1,200, a little over 1,200 in 2013, are then actually eligible for PCMH designation. So of those nominated eligible practices, this year, as Margaret mentioned, we implemented the honor roll, and this included practices that were designated in both of the previous years, so 2011 and 2012. And these practices are all just automatically designated regardless of their scores in 2013, and that was to create stability in the program. But if those practices have a quality, use, and efficiency score that is below the 20th percentile, which we consider kind of a minimum standard in the program, then they were put on probation and are at risk for losing designation in 2014. So we kind of give them a warning period so that they have to improve their scores or else they can lose designation next year. And then for the practices that are not on the honor roll, the practices in blue and green here, they had to have sufficient scores. So a quality, use, and efficiency score above the 20th percentile, had to have implemented at least 20 capabilities, and have a PCMH designation score, which I'll talk about how we calculate that, that's above a minimum threshold that was set by our leadership at Blue Cross. And that threshold kind of changes every year based on funding and how the practices are doing. So then after that process, most of our practices that were nominated were designated, as you can see the green and maroon parts of this graph. So one component of our designation score are the PCMH capability scores. And these scores are the proportion of possible capabilities that were implemented by the practice. So in 2013, we had 132 capabilities that fell into those 12 PCMH initiatives or domains, as we've been talking about. We also look at e-prescribing, which isn't exactly a domain, but is also a part of our PCMH program. Adult-only and pediatric practices have some slightly fewer capabilities that are relevant to their patient populations, so we calculate their scores out of just the capabilities that are relevant. In 2013, that was 128 for both. And each capability is given an equal weight in the scoring process, so we don't assign certain capabilities a higher weight and consider them more important than others. And PCMH capability scores were adjusted downward for practices that are in physician organizations with some sort of systematic over-reporting, and we did that using the accuracy factors that Mike mentioned. So the accuracy factor for 2013, it was based on site visits that happened in 2012, and as Mike mentioned, there were 323, and they looked at 40 randomly sampled capabilities during each of those visits, and the overall accuracy was around 95%. And we gave sort of extra credit to practices or to physician organizations if they adjusted capabilities after the site visits occurred. So we asked the question, if a capability was reported to be in place, but the field staff observed that it wasn't in place during a site visit, did that physician organization take that lesson and go and remove that capability from any future reports that they send to us so that they'd be more accurate? So if they did that, then we gave them some credit for making that change and shifted their accuracy upward. So after that credit was given, any physician organization with an accuracy of less than 90% were subject to the accuracy factor. So we didn't use this across the board. We really wanted to look at systematic over-reporting and not just a mistake here or there in capability reporting. And only 2 physician organizations were subject to the accuracy factor this year, and we applied them at the PCMH initiative level. So for instance, if a practice reported that there were 100% implementation of patient web portal, but their physician organization only had 80% accuracy, then that practice would receive an 80% for that domain. So the next part of our scoring process are the quality, use, and efficiency metrics. And we have 14 total quality, use, and efficiency metrics that we used in 2013 scoring. And they're all calculated using claims data from 2012 to account for the lag in when we receive claims data. And all of our metrics are divided up into pediatric populations and adult populations. We didn't want to combine those 2 populations together. So we have quality metrics that are largely based on HEDIS, and we have evidence-based care ones, which are basically disease management type measures, things like diabetes care, things like that, mostly chronic diseases for adult populations. And then we also have preventive measures, which for children would be things like immunizations and well-care visits, and for adults would be things like cancer screening. And those are composite scores combining multiple different metrics together. And then we also have utilization metrics. One is the primary care sensitive emergency department use, and this is based on the New York University algorithm, which assigns a proportion to each emergency department visit based on the probability that it could have been prevented through better primary care. And then we also look at low-tech and high-tech radiology rates, although we don't look at high-tech for pediatric members because of small sample sizes. And then we also look at generic dispensing rates and trends. So we have some kind of standard methods for calculating metrics that are used for multiple different metrics. And they're basically to just make scores as fair as comparable as possible. So one thing we do for most metrics is risk adjustment. Although we don't risk adjust any of our quality metrics, all of our utilization and efficiency metrics are risk adjusted. And then we censor metrics if the sample size is too small or if the metric is considered an outlier. And then we substitute those censored metrics with scores calculated using larger patient populations. And then metrics are standardized to the same scale so we can combine them and weighted based on their importance to the final score. And so I'll go through each of these steps in more detail. That's kind of an overview of the processes we use to calculate the scores. So for risk adjustment, we adjust for age, gender, and symmetry perspective risk score. And symmetry is the engine that we used that looks at risk scores based on predicting cost in the following year. And this basically answers the question, what would we expect this practice's score to be if they treated the PGIP standard population? And by using that same standard population for all of our practices, we reduce the differences in scores that are related to case mix characteristics like age, gender, and risk score. And we use regression models as the method to risk adjust as opposed to, for instance, direct standardization or indirect standardization, which we think is an enhancement when working with small sample sizes that we encounter at the practice level. So then we censor metrics as well. Metrics are censored if their sample size is too small or if the estimate is considered an outlier. And also for GDR trend, we censor if the GDR score is already so high that we feel like it would be difficult for that practice to improve. The censoring criteria is different for each metric, and it's chosen each year based on the distribution of metric scores, and I'll show you an example in the next slide. If a metric is censored, it basically means we feel that we don't have sufficient information to really evaluate that practice's performance. So here I show an example of censoring for adult primary care sensitive ED rate. So you can see the x-axis has the number of attributed adults, and the y-axis has a risk-adjusted rate of emergency department visits. And basically, we censor practices that have a very small sample size, so ones with less than 50 attributed members. We also sample ones or censor ones that have kind of an intermediate sample size, but have an outlier rate, so it's a very high rate. And our outlier status is shown there. So that's this gray box here. And then we also censor practices that have less than 10 adults with an ED visit, so a small a number of unique members within ED visits, so not letting one member influence that rate too much. And those are the practices shown in red here. And all of our censoring criteria is somewhat similar to this. So once a metric is censored, we have to do something to it to enable us to calculate the practices scores. And in this case, we use substitution. Over on the right-hand side, it shows our hierarchy in PGIP. So within the entire physician group incentive program, it's broken up into physician organizations, which we have about 40 of, as Margaret mentioned. Within those physician organizations, they're often broken up by geographic or administrative units, and we call those our sub-physician organizations, or sub-PO. And within those are the practice units. So when a practice has too small a sample size to calculate a metric, or for other reason is censored, then we substitute that score using values calculated from a larger population that practice came from. So for instance, if a practice had too small a sample size to calculate a score, we would look at nominated practices that are from the same sub-physician organization as that practice and see if we could calculate a score using that larger population that the practice came from. If we have too small a sample size there, we'll go out to the physician organization and then to the overall PGIP average in really rare circumstances where the physician organization is too small. The assumption here is really that nominated practices within the same sub-physician organization or physician organization, that same population, in most cases have similar processes and administrative structures in place. So we feel like the practice's performance should be somewhat similar to the average performance of that larger population. Whenever we combine multiple metrics together, we need to standardize to the same scale. And in PCMH designation, we chose to use percentile ranking to accomplish this. This shows an example of percentile ranking for the PCMH capability score, but it will be the same process for all of the quality and use metrics that we use. So for the PCMH capability score, there's kind of two clusters of practices, one with fairly high scores and one with fairly low scores. And you can see the percentile ranking shown here in the second horizontal line. And so our interpretation of, say, a practice that were right here in the distribution and had a capability score of 0.9, they did better than 94% of practices, so they're in the 94th percentile. So after we percentile rank all of our quality, use, and efficiency metrics, we weight each one based on what we feel their relative importance is to the overall final score. And then we add them up to produce this overall quality and use score. I mean, you can see in this table we have the weights for each metric. Adult practices are not judged based on their pediatric membership. They don't have very many. And pediatric practices aren't judged on their adult population. So each practice type has a different set of weights that we use. And you can see that some metrics have a slightly higher weight, and that would mean that our leadership either felt that it was more sort of key to PCMH for that metric to be performed well, or it means that we had maybe a larger sample size or variability, so we felt like that was a better performance metric. So after we combine all of those quality, use, and efficiency scores together, we aggregate that quality, use, and efficiency score and the PCMH capability score to get a final designation score. So the final designation score, as Margaret mentioned, is 50% from capabilities and 50% from quality and use. And we rank our practices based on that score, and those above the threshold set by Blue Cross are designated. And as I mentioned in the earlier slides, practices that are excluded from the rankings are honor roll practices because they're just automatically designated. Ones with too small a sample size to calculate this score, ones that weren't nominated by their physician organization, and then ones with like a low quality, use, and efficiency score or very, very few capabilities. Most of our practices have more than 20 capabilities. So after we designate practices, we look at performance comparisons between our designated practices and not in some of these utilization and cost metrics shown here. And this is basically just to make sure that our process really worked to create a population of designated practices that really does perform better than not designated practices. Some of the metrics shown here are things that are actually used in our designation process, like the primary care sensitive ED visits. And then some are not used in the process, but maybe related to some of the things we use in the process, like this ambulatory care sensitive inpatient discharges. And we're sort of gratified to show that our designated practices tend to perform better on all of these metrics compared to not designated practices, and they have in every year, even though we've increased the number of practices that were designated. So in 2013, our designated practices had 19% fewer ambulatory care sensitive inpatient discharges than the not designated practices. Okay, I'm going to pass it back over to Mike now to go through the evaluation of our program.
Thanks, Amanda. I'm just going to go, I'm going to talk about our evaluation efforts, particularly the article that came out in July in Health Services Research, looking at the association between medical home capabilities and various cost and quality outcomes. And then after kind of going through that, I'm going to talk about how we estimated our averted claims costs associated with PCMH implementation. Before I get too far into it, I want to acknowledge our partners in evaluation, so the University of Michigan School of Public Health, as well as the University of Michigan Department of Family Medicine. And the study was particularly funded by the Agency for Healthcare Research and Quality. And there's the reference for anybody interested in looking for that article that was published in Early View in July. So just our overall study design. So we're looking at all PGIP practices with at least one primary care physician, and we're looking at the self-reported capabilities they provided us in June 2009 and June 2010. And so a practice would have had to be in PGIP during both of those time periods and reported capabilities during both time periods to be part of the study. It's roughly 2,400 practices that fell into that criteria. It was a cross-sectional study. And I'll set this up a little bit. So we have capabilities present in June 2009, and then we're looking at outcomes from claims data that occurred during July 2009 to June 2010. So we have, what were the capabilities in place prior to the outcomes happening, and trying to predict, what's the association between those that were established before the outcome time period and that relationship with the outcomes. In addition, we also looked at newly implemented capabilities. So what changed between June 2009 and June 2010? What is kind of being able to differentiate, what are the effect of established capabilities on these outcomes versus capabilities that have been newly implemented during the time period. So as far as how we measured medical home, it's really unknown which domains are actually more important to cost and quality outcomes. We don't know which capabilities are more important to cost and quality outcomes. We kind of use the following approach to creating a measure of medical homeness for practices. So within each domain, each capability contributes equally to the domain score. So that, in essence, is the proportion of capabilities within that domain becomes that practice's domain score for that particular PCMH domain. And then, because we don't know which domains are more important, we essentially treated each domain equally and saying, we're going to take the average of the domain scores, and that's going to be the overall PCMH score. And what happens with that is ultimately you end up with a continuous variable where a value of 1 would equal full implementation of the PCMH model, and a value of 0 would equal no implementation of the PCMH model. And this method of measurement was published in the Annals of Family Medicine in a supplement about PCMH earlier this year. And this is just an example of how that calculation occurs. So this is looking at the patient-provider agreement. Here we have 8 capabilities according to the interpretive guidelines, but you can actually see that 6 of those capabilities are really the same capability along a gradient. And this happens in a couple instances within the interpretive guidelines. And so for those instances, we'll actually combine those into one and say, for this particular practice, they were at 60% out of a max of 90%. So we're going to say they're 2/3 of the way implemented with that particular capability. So really this domain has 3 capabilities in this particular practice that leads to a domain score of 0.56. And this is just a look at how, in June of 2010, how those scores looked at across our various practices that were part of the study. So here you can actually see, as Margaret mentioned, a lot of the initial emphasis being on test tracking results. or test results tracking, as well as extended access, preventive services, and really not a whole lot of implementation as far as patient web portal goes or self-management support systems. So there's definitely a sequencing or a variety of approaches that people are taking as far as implementation goes, because it's definitely not uniform across all the different domains, and it is, and from our observations, also not uniform across practices. So when we're getting to the point of modeling, we wanted to look at a variety of characteristics that might influence our outcomes that we wanted to control for. So we looked at a variety of practice level characteristics, looking at the risk score distributions of the practices and trying to account for that. And this is, in essence, looking at the chronic disease burden of the populations of the practices. Try to account for whether it's a pediatric practice or an adult practice, the size of the practice, is there an influence of larger practices or smaller practices on the outcomes? Also, whether the practice itself was a mix of primary care and specialty physicians, or whether it was primary care only, and then looking at the volume of Blue Cross patients within the practice. We also looked at a variety of market level characteristics, also some PO characteristics. We looked at, is it a large physician organization or a small physician organization? What's the Blue Cross market share in the service area of that practice? And then using the area of resource file to look at other like socioeconomic characteristics, like the median income or the availability of primary care providers, or whether it's an urban or rural setting. So the next two tables actually cover some of these characteristics and the distributions that we saw within our population. As you can see, early on, the program started in 2008, so we're looking about a year and a half in, and really the level of established infrastructure was still pretty small for most practices, or non-existent in some cases. But given a year and a half of implementation efforts over the course of that next year, there was actually quite a bit of implementation occurred. So that's why you see a large change in PCMH implementation in the second row there. In the second table, you can see things like the practice size of the various practices. So you can actually see our population consists of a lot of solo physician practices. Roughly 60% of our adult and family practices were considered solo physician practices, and about 46% of our pediatric practices were solo. And so, that's just one of the general observations we've had over time here, is that even though we have a lot of solo physician practices, they've been able to successfully implement PCMH to some degree, in part due to the assistance that is provided by their physician organizations. And we also have a good mix in terms of other contexts, so the urban-rural settings. So in terms of just generalizability, there's a lot of potential application of our results to what's going on nationally. As far as outcomes that we were interested in, we looked at two composite measures for preventive care, one adult composite measure, and these are similar to what is used in the designation program as well. But the adult composite measure being breast cancer screening and cervical cancer screening, the pediatric composite consisting of well-child visits as well as immunizations for both adolescents and children. For the adult quality of care composite measure, it's really kind of a hodgepodge of various measures, a lot of chronic disease management type measures, as well as efficiency of care measures that fall into the quality of care composite measure. And lastly, we looked at medical cost outcomes, and these are the paid costs for the claims, including the member liability portion of those costs. We did not include pharmacy costs, since it's a separate benefit and it's not universal across the members with medical coverage. And we looked at two outcomes, which in essence are really the same outcome, just stratified by the age of the population: the adult per member per month medical cost, as well as the pediatric per member per month medical cost. And as was mentioned at the very, very beginning when Margaret was talking about the incentive design, the fee uplifts associated with designation, the practices that are designated get an extra 10%. Well, that 10% is actually included in these medical costs. We did not try and take that out. So that component of cost is already included in the outcomes that we observed. So just some exclusion criteria we applied to to the data set before we did our modeling. So obviously, if you're missing data on a predictor or outcome, you can't really do much about that. We looked at sample size for some of the various outcomes before we included a practice in the sample, and these are all pretty similar to what we do with designation as well. We look for statistical outliers, as well as some influential observations using regression diagnostics. And then we also excluded pediatric practices from any of the adult outcome measures. Our modeling approach was a generalized estimating equation because really we were interested in estimating the mean effect of PCMH across practices. We also did some random intercept linear mix models to determine whether the results were variable by PO, which we really didn't see a whole lot with those models. But getting back to how PCMH was originally defined as a continuous variable here, where a value of 1 equals full implementation and a value of 0 equals no implementation. This is how, and that's kind of the second bullet under the modeling here about the effect estimate. In terms of how we interpret that effect estimate, it really represents the difference in outcome between a practice that has fully implemented PCMH and a practice that has implemented no PCMH. So here are the modeling results that are in that study. The first two I'll focus on are the preventive scores, and you can see in both cases the adult preventive composite score as well as the pediatric preventive composite score are both significantly associated with the level of medical home implementation in the practice. And what this translates to, so when you see that 5.1% for adult preventive composite, that would in essence say that if a practice had fully implemented PCMH, their composite score would be 5.1% higher than a practice that has never implemented any PCMH infrastructure. Likewise, for pediatrics, a practice that had implemented fully implemented PCMH would be 12.2% higher on that score than a practice that had never implemented PCMH. Now, the change scores on the side have kind of an odd interpretation because typically they need to be evaluated in context with the baseline score. But if you really want to, like an official interpretation of these would be like, so if a practice had no previous PCMH implementation infrastructure, and they decided to implement everything in PCMH over the course of the year, you would expect that their composite score would be 3.3% higher than a practice that didn't have any prior implementation and decided not to implement anything during the course of the time period. So the change scores are a little harder to interpret, but in essence it's showing that, at least for the adult preventive composite, that it's a pretty comparable number, so like the impact on breast cancer screening and cervical cancer screening might be similar between capabilities that have been established as well as the newly implemented capabilities. Moving on to the quality composite scores. The adult quality composite, while it's not statistically significant, it is pretty close. We actually see statistical significance in the change in PCMH implementation. And remember, this is a hodgepodge of a lot of various measures, so it very well could be that a number of those measures are impacted by PCMH, and we're just getting a couple measures in there that aren't being impacted, kind of lowering the composite scores associated with and impacting that association. And then lastly, when we get to the medical costs, here, for the most part with pediatrics, we really don't see a lot of impacts on costs. You kind of see a slight increase in costs potentially for the newly implemented capabilities that were going on during this time period. But when we look at the adult costs, based on the capabilities that have been established in place for a while, we actually do see a pretty sizable association there. While it's not statistically significant at the 0.05 level, it's right at that threshold, so it's at least worthy of consideration that, you know, we want to try to estimate savings from this value. It's not so far from that 0.05 value that we're going to say it's not related with PCMH at all. So here, just kind of going through the interpretation of the estimate again. So a practice that had fully implemented PCMH prior to the time period would, on average, have $26.37 lower per member per month cost than a practice that had not implemented any PCMH implementation prior to the time period. So you can imagine that while a practice that might have only had 20% infrastructure in place, when you start getting into the actual impact of that practice, a practice that only had 20% in place would actually only be about a $5 lower PMPM than a practice that had no implementation. And so while the full effect might be $26, in actuality, because a lot of these practices were early in the stages of implementation, the actual impacts for the individual practices is much lower than this currently. So before I get into calculating the estimated averted costs associated with PCMH implementation, just want to look at some of the strengths and limitations of the study. It was generalizable to a substantial portion of our primary care community, roughly 70% of our primary care physicians, and 82 of 83 counties in Michigan. And our population is coming from a wide variety of contexts, both urban, rural settings, high SES, low SES, and large and small practices. And one of the real strengths of this study was mentioned at the very beginning by the moderator. PCMH, looking at PCMH as a continuous measure instead of an all or none variable, allows us to estimate the effects of incremental improvement. Some of the limitations, obviously, it's a cross-sectional study, and we'll have to see whether these results persist longitudinally. We can't really control for physician motivation in this analysis. And while Blue Cross's program has similarities to NCQA and other programs of its kind, it still is unique, and so the results here may not fully apply to other programs nationally. Just some of the next steps as far as evaluation goes. As I mentioned, do our results persist longitudinally? Are there contexts where the model is more or less effective? And we feel we have sufficient information about a variety of practices, a lot of different contexts to answer some of these questions. You know, what impacted we're in the process of trying to figure that out, right? Inside with reduce off for specialists, reduce rates of pitching, those types of things. A lot of these capabilities take hacks that our specialists are having as well. So now that was the study itself. So now the next couple of slides will go through how we estimated our averted claims costs. What we wanted to do is apply the model results from that study to our capability data that's been reported to us over a series of time. And this requires a few key assumptions. The first and probably one of the more important ones is that we require at least 1 year for the capability to achieve its full effect on averted claims. So the first year it's implemented would be a newly implemented capability, but then the next year it would be considered an established capability. And that may be a rosy outlook as far as capabilities go, because it may actually take 2 or 3 years ultimately before a capability would really begin to achieve its full effect. Another assumption is that medical home implementation is relatively minimal in Michigan outside of PGIP. We do have a lot of evidence to support this in terms of most practices in Michigan seek the Blue Cross designation. Very few have gone and sought like the NCQA recognition. And we actually have other payers in Michigan that recognize our designation. And so we feel pretty comfortable in saying that most of the implementation that's going on is happening within our PGIP program. And then just a couple of other key important assumptions that our parameter estimates won't vary with time, and that the association that we saw at lower levels of implementation will apply at higher levels of implementation. So here's just the general calculations for estimating the averted costs associated with PCMH. So the averted costs at the start of the time period here is equal to, so the beta estimate from the regression model, so the $26.37, and you would then multiply that by the PCMH score of the practice after taking away what they came into the program with. So these would be the capabilities that were implemented during the course of the program that have now become established, and multiplying it by that regression estimate for the established capabilities. You would then take that per member per month cost and multiply it by the member months attributed to that particular practice, and that would give you the estimated averted costs for that practice. Similarly, repeat this process for the change score as well, the change in PCMH implementation. And then you would sum those costs across all practices. And so what we see here is that early on in the program, we weren't seeing necessarily a whole lot of averted costs. But over time, as capabilities had been implemented and the longer they became established, we began to see increases in the averted claims costs associated with PCMH. And part of the way that we designed this too is one of the reasons we didn't look at designated versus non-designated practices to look at the impacts of PCMH is that we really wanted, we would really be short selling ourselves on the impacts of our program, because the non-designated practices are actively engaged in PCMH implementation as well as a result of our program. And so we would actually be comparing two elements in our program against one another. So we would be shortchanging the impacts of our designated practices by comparing them to our non-designated practices. And we'd be completely ignoring the impacts of our non-designated practices and all the efforts that they've made as far as PCMH implementation to date as well. So over time, we've seen relatively nice increase in averted claims costs, and we expect it to somewhat taper off in the future. Well, it will continue to rise just because you know, practices have already implemented a lot of capabilities, and so there's only so much more that they can implement, and there's only so many more practices that can implement more capabilities, and so eventually this will start tailing off, but there's still a lot of opportunity to add more averted claims costs to these numbers. So just as one general last slide here, oh, I went too far. So just some of the general summary observations that I've made and we've made overall when evaluating this program. One thing that I mentioned earlier is that we've been able to see that small practices are capable of implementing PCMH as long as they have adequate support from their physician organizations. One other thing that was important is that it took us several years to standardize our interpretations of capabilities across providers. And so the importance of the site visits, as well as getting provider feedback, recognizing that, you know, a patient registry is going to look potentially 20 different ways, depending on the context of the practice. And having that bidirectional feedback is really important to the program. As with any program, routine process evaluation is important for meeting both the program's needs as well as the participants. And then just kind of one analytic observation that I've made is that we've used 3 different PCMH scoring approaches, but they all have specific purposes within this program. One is to focus on just capability implementation. That's how we reward continuous improvement and just that capability reimbursement every time they implement something new. Then we have the second way of measuring PCMH for designation purposes, which combines that first measure with the quality and use and efficiency outcomes. And that becomes another way of rewarding physicians and another purpose for a second scoring approach. And then our third scoring approach, just recognizing that there's not a lot of literature out there about, you know, what are the best elements within the medical home as far as, you know, which ones have the greatest impacts on cost and quality outcomes, so that we had to create a third measure for the purposes of evaluation. And so even though, you know, it's just one program, but we actually have 3 ways of analyzing PCMH, and they all serve very different purposes. And I think that's important when you start thinking about other PCMH programs of, you know, what are you trying to achieve, and are you using the types of measures that will help you achieve that? So with that, I'm going to open up for questions.
All right. And before we go into questions, I just want to say thank you all for an excellent presentation and for sharing a wealth of information with us today. I do want to remind folks that all this information, including the recording and the slides, will be available on our website at pcpcc.org. If you go there, you'll notice a map of Michigan right on the home page. You can click there to access the information. Also, if you go to the bottom of our home page, you'll notice a link that goes directly to webinars. And that's another place where the information will be posted. Feel free to check it out yourself. You can also share it with colleagues that couldn't make it today. And the page will also include a link to the article we discussed that was published in July 2013, Health Services Research. It's a really interesting read, especially for those of you that are implementing components of the medical home and are trying to assess what their impact might be on quality and costs. Certainly a complicated journey. And again, thanks to Margaret, Mike, and Amanda for a terrific job. And on behalf of the PCC, we appreciate you sharing all this information with us today. As a reminder, to participate in the Q&A, you can type your question into the question box on the bottom of your screen. And in the meantime, we have a few queued up that I will read and let our panelists address. I'm going to start with Sean Gracie's question. Did Medicaid beneficiaries participate in the PCMH program?
Thanks for that question. What I should clarify is that one of the principles of our PCMH program is that when these capabilities are implemented in practices, they are to be made available, or they are to benefit the care of all the patients in the practice. That doesn't apply when there are distinct benefits that one group of patients has and another one doesn't. For example, care management services delivered by a care manager and billed and reimbursed. But in general, and I think it might be helpful, and I think there was actually a question asking to define a capability, and I think it might be helpful if I read a few examples, and I think it might give you a better understanding of what a capability is and how it could apply to all the members in a practice, because we don't limit it by payer type at all. So, for example, in the patient registry domain, one capability is that the practice has a patient registry for diabetes patients. And then another capability is the practice has a registry for asthma patients. Another one would be the practice has their registry is electronic. And then another one would be the registry incorporates information on healthcare services delivered at other sites. So that's how we built the stepping stones. We broke it down into pieces. One more example, for example, extended access. One capability is the patients have 24-hour access to a clinical decision maker with a feedback loop to their medical record. And then a next capability would be that the clinical decision maker has access to the EMR or the registry during the phone call. Then we have other capabilities that speak to after-hours care and same-day appointments. So those kinds of capabilities would apply across the entire patient population of the practice.
Great, thank you. So our next question is, how closely do your criteria match the criteria necessary for meaningful use certification? From David Dude.
So meaningful use, there is some overlap. If you look at the criteria, there are some similarities, but meaningful use focuses obviously on electronic health record use, and our focus has been more on population level management. So the patient registry domain is our principal domain that speaks to creating electronic records that help the providers track patients' care. So I mean, if you went through the individual criteria and meaningful use, you would find some that there's some similarity and some overlap, but our registry domain has a different focus.
Okay, great. Thanks, Margaret. Another question from Chris. Can practices get credit for completing a partial capability, such as individual care tracking, or do they have to complete all components to get credit for that specific domain?
So I hope that the examples I just provided will help to answer that question, because the answer is yes. Every individual capability that gets implemented earns an incentive reward, and the number of capabilities varies by domain. So, for example, in the extended access domain, there are, I'm going to look it up, there are 9 individual capabilities. So, yes, any capability that gets implemented gets credit and earns both an incentive payment plus a point value in the designation scoring process.
Okay. And this is an interesting question from Bob. We get this a lot at the PCPCC, and wondering what your experience has been. Have you estimated practice transformation costs for clinics, for example, a specific PMPM to implement the PCMH capabilities that practices are adopting?
Well, we have certainly had many conversations with our practices and providers about the costs of implementing PCMH capabilities. No, I can't say that we have that those conversations have resulted in a single PMPM estimate. One of the things that was very important to us in our PCMH program was create a program that would allow all kinds of practices, solo practices, rural practices, group practices, integrated health systems, and loosely affiliated independent practices to implement these capabilities. And so the costs are going to vary tremendously across those various kinds of healthcare organizations. One of the things that the strengths that we of our program is, I mentioned before, the physician organizations. And for many of these capabilities, it's actually the physician organizations using the incentive money that we pay them through our PGIP program. They will use that to implement capabilities across all their practices. So, for example, they may purchase and implement the registry system for all their practices. They may, for the linkage to community services domain, the physician organization itself may take on the responsibility of developing the resource book, the database of all the available community services. So the costs can sometimes reside in the practices, but sometimes are funded by the physician organization.
Okay. And I do want to remind folks that the webinar will be available on our website at pcpcc.org. You can access the information within 24 hours. Our next question from Anne, will an increase in averted claims costs translate to reduction or increase in expected mortality in your patient population?
So I think that one's for Mike.
Well, I think that would be unclear whether the costs themselves would directly impact the mortality. I mean, it could very well be that if patients are being more efficiently managed and being taught self-management support techniques, that a person that is at higher risk of mortality, even though they might be expending more in terms of the preventive and proactive type of care that PCMH is intended to provide, if they're less likely to have adverse events like inpatient admissions and ED costs, that may demonstrate both the savings as well as an impact on mortality as well.
Thanks, Mike. This question from Rita. Do you have a sense of which designation elements are most critical for success for practices?
Mike, you've looked at that. Do you want to address that?
I don't know if we know which ones are most critical. We know that initially a lot of the implementation, and maybe it's just low-hanging fruit, but maybe it's also what practices prioritize, which are things like the extended access and test tracking and follow-up. With extended access, you can definitely see instances where, just from practice feedback, where they talk about, I didn't realize I could open up 20 or 40% of my appointments to open scheduling, and seeing that the volume of their wait list declining, and what kind of impacts is that having on the emergency department use that their members were having. So there's definitely capabilities that providers prioritized, whether that's simply because it's low-hanging fruit or whether they felt that met the needs of their patient population is another question.
Thanks, Mike. Another question from Chris. Did you say designation is at the practice level or physician level? If practice, then assume all physicians within the practice have to be on board with performance improvement?
Yeah, so designation happens at the practice level, although the evaluation and management fee uplift that we talked about is at a physician level for all primary care physicians in the practice. And that is true that they'd all have to be on board with practice transformation.
Absolutely. I think a commitment to quality improvement and a culture of quality improvement is essential for these type of projects, and your article definitely confirms that. There's an earlier question from David Dude. Have you adopted a holistic care approach in looking at your outcome measures, or do you have carve-outs for prescription behavioral health? I do think you guys addressed this, but I don't know if you want to go a little deeper into the role of behavioral health and other specific areas.
Well, we do have, there are certainly elements in our PCMH model that speak to capabilities that would be supportive of behavioral health. We haven't carved anything out separately. In our organized system of care program, which is kind of the next generation of a patient-centered medical home, we are getting even more explicit about the need to incorporate behavioral health into the management of the patient population. So it's very much, I would say, a holistic approach and integrated into what we're trying to do.
Great. A question from Larry. How does the PCMH bonus structure percentage compare to fee-for-service payments and overall compensation for a PO, and is fee-for-service increases capped?
Oh, goodness. Okay, I'm going to have to read that question.
Yeah. Yeah. I think the first question is, how does the bonus structure percentage compare to fee-for-service payments?
The bonus structure. Well, so I guess by bonus structure, they're referring to the E&M uplift. And we estimate that our 10% E&M uplift, or we call it the uplift, the fee increase on our evaluation management codes, we estimate that that amounts to about $8,000 per practice, or sorry, per physician per year. And so when you say how does it compare to fee-for-service, I mean, it's an addition to, so it's an additive amount to the fee-for-service payments.
Right.
I mean, it's an increase in them, basically, yeah.
Okay.
And what's the second part of the question?
You know what, that one's a little bit choppy, so I think I'm going to move on to the next one from William. Have you implemented a care manager outreach to higher risk members at the practice level?
Oh, that's an interesting question because it's something we're working on right now. In our individual care management, actually there are 3 domains within our PCMH model that are very relevant to care management. There's the individual care management domain, self-management support, and care coordination. And we did actually implement a provider-delivered care management pilot a few years ago that we've now expanded into a statewide program. We have about 400 practices participating in that now, and they are addressing the delivering care management across the continuum of patients who can benefit from it. And we are actually now in the process of developing a program that will be specifically focused on Medicare Advantage high-risk members. So that's something that's underway. But the current provider-delivered care management program includes 2 types of care managers who are trained to work with the most complex patients, and care managers who address more of the moderate complex patients. And that program is ongoing, and yes, they do outreach to patients. And we, under our pilot, experienced very high engagement rates. About 50 to 70% of patients who were contacted engaged with their care managers under a pilot.
Great. Okay, so we are almost at the 1:30 mark, and I will ask one more question. As a follow-up to the question, oops, I just lost it. As a follow-up to the question regarding Medicaid beneficiaries, does Michigan State Medicaid program or local MCOs promote PCMH for their enrollees?
Do they promote, in other words, do they try to steer their members?
Right.
I don't know the particulars of that. I know that when I referenced the provider-delivered care management program is actually part of the CMS demo, and so it's a statewide multi-payer program that Medicaid participates in, and they have been active in steering their members to those practices, all of which are PCMH designated.
Right. Okay, excellent. Well, thank you all again for your time and all the information you provided today. Just one more reminder that the information will be available on PCPCC's website. We'll have the recording and the slides up there. And thank you all for participating, and enjoy the rest of your day.